All right, let's get started. So our first question, you guys able to see the PowerPoint, okay?
Yeah.
So this was a question about a gentleman that had an MVA, low GCS, and then had an EBD placed to measure intracranial pressures. You notice that the EBD pressures are high for the first 3 hours. It's very important that they clarify that it's sustained for 3 hours because a single high EBD reading is not indicative of high intracranial pressures. It's really sustained reading. Usually more than 15 minutes is when you need to act. And so the right answer here is that prevention of hemodynamic instability causing hypotension is what you need to act on. And the reason for that is, a few things. So first is, I think for, all the residents in the room or for those that haven't done neuro ICU, let's just kind of understand what an external ventricular drain is. I don't know if anyone's heard of the Monroe-Kelly doctrine, but the idea is that when you have something that's causing um, that's something new that's taking up space in your brain, right? Unfortunately, because of the way the skull is, you can only pressure can only disseminate downwards, right? Because the skull is not going to be able to expand, right? Like when you build up extra pressure in your body, in your lungs, in these other extrathoracic space or extracranial spaces, your body is able to compensate for that increased pressure by increasing the volume. Your brain cannot do that, and that's why we get herniation, right? So you've got like a fixed amount of tissue, you've got a fixed amount of venous blood, a fixed amount of CSF. Anything that would cause a change in a significant amount of volume is going to, even a small amount of change in pressure is going to cause a dramatic change in your volume. And so we talk about this as like, the compliance in the brain. And so once again, just clarifying here that even a small change in volume is going to cause a large change in pressure, or a small change in pressure is going to cause a large change in volume. And so we can estimate the cerebral perfusion pressure based on your maps. The idea is that like your total intracranial pressures plus your map is equal to your plus your CPP, which is your cerebral perfusion pressure, which is what we care about, is equal to your map. So the idea is that in these patients, you commonly heard that, okay, I don't know what the cerebral perfusion pressure is, but because of bedside assessments, whether it be by ultrasound, hemodynamics, you see that, okay, you know what, my intracranial pressures are high. So how can I ensure that when that intracranial pressure is high, my cerebral perfusion pressure isn't compromised, and the goal is to increase the map, and that's where you can argue for a higher mean arterial pressure. And so the few different ways of getting an external ventricular drain, you can do a bolt, not as invasive as a drain, but you can't adjust them, you can't get samples, you can do the drain as a subdural catheter or down into the ventricular catheter, ventriculostomies, and obviously intraparenchymal yuck. Things that you need to know about assessing a curve, it's pretty straightforward. The first waveform where you see P1, P2, P3 is normal. P1 is that systolic curve. So when the ventricle contracts and you see that compliance against the aorta, that's P1. That should be the highest, right? That's your systolic blood pressure, your heart contraction. P2 is basically the compliance of the brain. And then, so the less compliance, the higher that pressure is going to be. And when you can even see that when it's really, really bad, it combines. So patients that have high intracranial pressures will look like that second or third figure, but what you want it to look like is that first figure. So just like how we assess our arterial waveforms and not just look at the map, um, same with these EVDs, we should really be looking at the curve and not just the number. And so there's all these different interventions that you can do, right? And depending on how severe it is, like initially you want to think about osmotic therapy, you want to make them normal temperatures, in really severe cases like in tier 3, as you're acutely trying to get them to the OR to try and relieve the pressure, you can do the safe stuff like, go for a lower temperature, you can hyperventilate. These are all acute things that shouldn't be maintenance therapy. The hypertonic, yeah, somewhat maintenance therapy. I think there's going to be down the line evidence that even with hypertonic, you only do it as a resuscitation, because if you bring them to high sodiums and then they herniate, then you kind of lost that osmotic gradient to use. But the most important thing, the thing that evidence supports best, is making sure that they maintain that higher map. And it all comes back to that equation that your cerebral perfusion pressure plus your intracranial pressures is equal to your map. So if you have high intracranial pressures, you can't control the cerebral perfusion pressures, but what you can control is your map. So by increasing your map, increase your cerebral perfusion pressures. Here's some other stuff that you can do. Obviously, avoid anything that's going to cause any additional strain of the brain. Obviously, for severe cases, you want to consider decompressive craniectomies. And then obviously the same idea of the map, you want to reduce pressures in other compartments. So, avoiding excessive PEEP in the abdominal compartment, draining any acidic fluid if it's there. These are all things that will increase in your map in small amounts, but it can definitely help your cerebral perfusion pressure. Next question. So this was the one about a patient with like hypertensive nephropathy, had a renal transplant, now with ARDS. They're on the vent. They have a PEEP of 12. Their peak airway pressure is at 35 with a plateau of 26. There's obviously a vent question. You see their gas. Then you change them to pressure control. And then you see a PEEP of 14 or 12, sorry. Now your peak expiratory pressures are 26. Your tidal volumes that you're expiring is only 200. And then you see that, they're becoming more hemodynamically unstable. They're requiring pressors. It's a horrible gas. You can obviously see they're becoming hypercarbic with a notable lactic acidosis. So what, it's very important to pay attention to the question stem here. What ventilator adjustment could have resulted in earlier identification of this acute change in clinical condition? And so what you're really looking at for here is that you see that X-ray, right? And what do we notice on the X-ray? Pretty obvious, right? You guys see this? I don't know if you can see my drawing. Right, what's happening here? You have a pneumothorax, right? You don't see any lung markings in this space that you throughout this space. So the question is, okay, we talked about a few things about what's important to know here is that the patient has a pneumothorax, right? And so we talked about the numbers that they gave, once again, for mostly for the residents. So the pressures that we care about are your peak pressures and your plateau pressures. And then you have your driving pressures, which is your plateau pressure minus your PEEP that you apply. And so what's important to know here is that this is all indicator of compliance and resistance, that you can pick up patterns. So when you do your inspiratory pause, you get your plateau pressure. If you get a rise in your peak pressures with a rise in your plateau pressures, that means this entire area has increased. And so that means the compliance is reduced. Things that would cause a reduced compliance, it could be things like, pneumothorax, it could be pulmonary edema, it could be ARDS, anything that's causing inflammation in the lungs that would decrease the ability of the lungs to expand and be less compliant. And then obviously you get a rise in peak pressures without a rise in your plateau pressures, meaning this grade goes up. That's a change in airway resistance. The tube could be kinked. They could have a lot of secretions in your endotracheal tube. You'll see patients that you intubate with a very small endotracheal tube. We'll obviously be dealing with that as well. And so once again, just this diagram kind of showing the same thing. Obviously keep differentials in mind. I really like this mnemonic for how to approach this patient. So, what you see high peak pressures. Your trick mnemonic could be dopes and dots. Dopes for how to diagnose it, dots for how to manage it. So it could be a displaced ET tube. It could be obstructed. It could be a pneumothorax. There could be an equipment malfunction, such as they could be disconnected. They could be breath stacking, so like they could be auto peeping. And then you fix that with dots. So like you could disconnect them from the ET tube, from the ventilator, figure out what's going on. You oxygenate them with a bag valve mask that the resistance is. Can look at the tube position, get an X-ray or use ultrasound. And then you can tweak the vent. You can see whether they're auto peeping, you need to adjust some things. And once again, really using that ultrasound, right? Ruling out a mainstem intubation, ruling out pneumothorax. So really the approach for when your ventilator alarm goes off. Well, the question I think is important to assess here and why you would be able to get that answer is that understanding the difference between volume control and control, right? So we talk about the variable set and the variables that you'll see and the variable can change, right? So you are in volume control trying to set a tidal volume, your goal tidal volume, which we use very commonly. Then what you'll see, volume curve is black, the green curve and the patient effort, is in blue, which we don't really assess at bedside. But and then red is your airway pressure. So in volume control, you set the tidal volume. In pressure control, you set the pressures. And what you'll see is that the other variables, such as the volume or the pressure, will change based on the number that you're setting. And so when you have a pneumothorax on someone that's on pressure control, you're not going to see high airway pressures, right? Does that make sense? Because you've set the airway pressures that you're going for. But what's going to happen when you have a pneumothorax is that because there's decreased compliance, once again, the compliance has decreased, right? We saw the peak pressures and the plateau pressures go, we saw the peak pressures and the driving pressures go high, aka decreased compliance. You're just going to get less tidal volumes. And so what you have to do is you have to, when you switch someone to pressure control, you have to manually change the alarms so that it detects a lower tidal volume. And so if someone has a pneumothorax, you're going to get less tidal volumes, but you're not going to get high airway pressures like you would in volume control. I've seen the mistake done before, and then obviously they see the patient not getting their volumes back, and that's how you realize they have a pneumothorax. And so, yeah, any questions about that? Cool. This next question was about the 40-year-old gentleman who had asthma, was in severe ARDS. You see their vent settings over there. Once again, inspiratory pause of 27 and expiratory pause of 17 with an inspiratory pressure of 34. So their intrinsic PEEP, meaning their end expiratory pressure minus their wide PEEP is 1, and they're getting a low pulse ox. You put them in a prone position. Now your end inspiratory pressure, meaning your plateau pressure, is 30, and your end expiratory pressure is 26, and your tidal volume is only 200. So if your end expiratory pressure is 30, that means your intrinsic PEEP, if your PEEP is still 16, is 14. So what does it mean when your intrinsic PEEP is really high? You're auto PEEPing, right? There is air that is getting in that is not being able to leave. And that's probably the cause of your high peak pressures. And you just prone this patient. So what do you think is going on? Well, likely, if we think about our previous diagram, right, you can also look at the peaks and the plateaus with that same algorithm, is that you see your peak pressures increase, but you don't really see your plateau pressures increase. So you know that there's an issue with airway resistance, right? And so airway resistance could be that it's not going to be a pneumothorax, so you're not going to look at C. It's not going to be B, because that would cause decreased pressures, and it can't be air because then you would have a leak. So the answer has to be D, right? That there's some cause of airway resistance, and likely you just prone the patient. And with the anatomy, they were probably just put on their head down, and now they're kinking the ET tube. So it's very important that you check the patency of your ET tube. That's why we don't prone and walk away. We always check what's going on. And yeah, pretty straightforward, I think. Pretty much what I was saying in the diagram. We have an issue with airway resistance. And so you can see that on the flow diagrams, I don't like using the flow diagrams to detect auto peeping because you can always miss it and it's so subtle. But I do like using the pressure diagrams that really rely on the extrinsic peep. So instead of clicking the inspiratory pause, you click the expiratory pause. You compare that number to your peep, and if you see it higher than like 2 to 5, you're probably auto peeping and you need to make some vent adjustments. Or check the anatomy. Next question, you have a 64-year-old with cirrhosis, and they fell at home and fractured their femoral neck. Then they got a hip arthroplasty. They went to the ICU for persistent hypotension. They're on pressors. Methylene blue is given for refractory vasoplegia. You're called for worsening hypotension disorientation. The blood pressure is still low. Now they're on norepi and vaso. They're tachypnic. They're diaphoretic. You see rigidity and hyperreflexia. That's your answer right there. Once again, they see rigidity and hyperreflexia with spontaneous clonus. I think the answer is pretty straightforward there. You're having, anyone know? Rigidity, hyperreflexia, clonus.
Serotonin syndrome.
Yeah, right. Just keywords that you have to know. And so what caused it? Well, you've got, just reviewing what serotonin syndrome is compared to your other neuromuscular disorders. It could be an anticholinergic. This is really a table you have to memorize. The things that I remembered is that you'll see hyperreflexia and serotonin syndrome. And then you'll see like rigor mortis, which is like just continuous rigidity in malignant hyperthermia. And then neuroleptic syndrome is like the lead pipe decreased reflexes, and then the person's obviously like diaphoretic, but their other cholinergic symptoms are not abnormal besides the sweating. You just have to look at this table over and over again. So serotonin syndrome, really looking for that mental status change, that hyperreflexia, that clonus. The treatment here really is benzos. You can cool them down because their temperatures will be up. And then the fun one is cyproheptadine. And so what can cause it, you think about monoamine oxidase inhibitors, serotonin releasers, and SRIs. And so, any combination of monoamine inhibitors with SRIs or serotonin releasers will cause it, but the serotonin releasers with SRIs will not cause it. And the drugs here were the SSRI plus the methylene blue. And so your treatment here is cyproheptadine. Reasons to not use methylene blue. The evidence for refractory shock isn't that great anyways. But if you're concerned about, RV failure because it will cause increased pulmonary vascular resistance, you'll obviously have to worry about your pulse ox. Be careful at high doses in patients with a G6PD deficiency. You'll get hemolytic anemia. And then obviously, any other monoamine oxidase inhibitor that's on. It'll cause some medication to accumulate, which is why I'm relying heavily on my pharmacist, unless it's in the middle of the night. Then don't ever use it in a pregnant patient because of placental vasoconstriction. Question 5 was a 80-year-old that had a right proximal femur fracture due to a fall, had AFib, was put on metoprolol and fractional heparin. 2 days later, got a hematoma. Briefly stopped the anticoagulation. Then a few days later, they had hemoglobin that was downtrending, a platelet count that was downtrending, which was normal prior to surgery. Creatinine is 2.1. Liver enzyme tests are normal. They threw in the answer pretty much by telling you that an ELISA was ordered for antiplatelet factor 4 and it was positive. You're waiting for confirmatory testing. This is like the main pearl that I think everyone knows, because I do think that we severely overorder this test at Inspira. But in addition to discontinuing heparin, what is the most appropriate treatment? And the right here answer here is argatroban. Quick review. So there are many, many, many other causes of thrombocytopenia besides HIT, but the way I think about it is things that would cause decreased production, which is the majority of the times that we see. And then second most common, I think, is redistribution, and then finally destruction. If I'm not seeing evidence of destruction on the smear, which I'm ordering every time, it's not going to be HIT, right? So you think about like microangiopathy, antibody-mediated autoimmune disorders, HELP syndrome, and then obviously valves that are sharing up your platelets. But more likely, it's likely due to an infection, which is, someone that's severely septic, especially with gram-negative bugs. If they're deficient in certain nutrients, for example, you see that concomitant high MCV. But these are all causes of chronic thrombocytopenia, not acute. And then, acute could be due to large volume resuscitation or portal hypertension after resuscitation. So the way I approach it is I get the smear every time. I look at the differential, and then I'm looking at the smear for schistocytes. If it's there, then, I'm thinking DIC or TTP or HUS. If I see a normal WBC, I'm pretty much convinced that it's, likely due to an infection or nutrients, because if I'm getting that high WBC count. And then otherwise, yes, fine. If my clinical suspicion is high, I'm ordering these other tests. But if I'm concerned about HIT, right, to decrease unnecessary ordering of tests and switching from heparin to an alternate anticoagulant, I am using the 4T score, right? And so everyone freaks out about having HIT. It's important to know because the board, they love it on the boards, both internal medicine and critical care. But really, you have that antibody towards platelet factor 4 when heparin combines with it, binds to platelets, you build that immune complex, and then that eventually causes clotting. You use up all your platelets in clotting, and then you get secondary thrombocytopenia. But these patients present as clotting, not as bleeding. And so if you suspect it, use a 4T score. If it's high, or even if it's moderate, you enter that confirmatory testing, the antiplatelet 4 antibody ELISA test. In the meantime, with anyone that's HIT and they're on heparin, you have to stop the heparin and switch them to something else. And so there's a long list of drugs that you can use. I think all we really need to know from a critical care standpoint is that, the two big ones to remember are gatroban and bivalirudin, because they're the only direct IV thrombin inhibitors that you can use in HIT. Argatroban being the first line. Just be careful in patients with heart failure, liver disease, or after cardiac surgery. You can use bivalirudin in patients requiring emergent cardiac surgery or PCIs. Just be careful to carefully dose them in hepatic and renal dysfunction. So when I think about switching to HIT and I want something IV, I'm thinking argatroban or bivalirudin. First line being argatroban unless I'm going for emergent cardiac surgery or PCI. Then obviously with then you just have to look it up if you're thinking about something that's slower. We don't really use ganoparanide anymore. I know we used to use it. And then, yeah, cool. Just have to be really careful about renal and hepatic insufficiency. Next patient, you have two patients make the ICU for an NSTEMI and the other one for a stroke. And both patients have a pulse ox of 94%. As part of the admitting orders, what do you do about the nasal cannula? You have to be careful about this because the majority of our nurses are going to be putting these patients on nasal cannula. And the right answer is what? Is that neither of these patients need oxygen, right? So we talk a lot about the controversy about putting oxygen, like for example, STEMI, everyone thinks about Mona Bash, right? That's wrong. There's no reason to put oxygen on all these patients. So multiple trials, the Detox 2 trial, the Avoid trial, and the SOS trial for stroke, basically showing that, they studied patients that were getting prophylactic nasal oxygen versus just breathing ambient air, unless their pulse ox fell to less than 90%. And you saw that there's no difference between the groups in one in mortality, reinfarction rate, or troponin levels. And then in the patients that you saw with stroke, there was also no difference in death or disability at 3 months. And then another trial where they studied something similar, they saw that there was a signal of injury with higher levels of oxygen. And then they also saw the patients in the group that did not receive oxygen did have lower mortality as well as less shock episodes, liver failure, or bloodstream infections. I don't know if that's a correlation or a cause, probably just a correlation. But once again, then there's also a study doing something similar in patients with septic shock, and titrating them to an FiO2 of 100% versus 88 to 95, and the trial stopped because you saw patients who had really bad damage from being hyperoxic. So, oxygen is a drug, and 88 to 92 in your ICU patients. All right, I have personal trauma from this question. A 78-year-old is admitted with septic shock. They got this echo, so part of that septic shock is obviously resuscitating them. And so what do you guys see? Anyone figure out what's abnormal on this echo? And let's start going through how to label the echo. So the first thing that when you look at any echocardiograms, obviously figure out the view. So your view is your parasternal long axis. So this is your RV. Sorry. This is your LA. This is your LV. This is your LVOT. So, the abnormality here is this. Anyone know what that is?
Descending aorta, right?
Sorry?
Looks like a descending aorta.
So would your descending aorta be inside or outside of your pericardium? So the way to figure it out is that look for the pericardium, right? The pericardium should be a thick hyperechoic border. You see your pericardium going like this.
I was told to.
The right thing about the descending aorta, that is right here, right? So it's outside the pericardium. This structure, which you usually don't see, is inside the pericardium. And so you know that if, when you think about what this is, that's a pleural effusion because it's obviously outside your pericardium. So really use that pericardial border. So that is an enlarged coronary sinus. Usually you may or may not see a coronary sinus, but it's always going to be inside your pericardium. So you have this patient with a enlarged within a large coronary sinus that it's usually not that big that you pick it up on echo. And so it's a congenital abnormality. Usually it's much smaller than that. And so when you're thinking about a congenital abnormality, you want to think what connects to your coronary sinus, right? You're going to be draining your venous system into your right atrium. But what if I said that sometimes, actually, before I even get to that, I will get to this question, this diagram. All right, you guys see this chest X-ray? Gibson, can you tell me what's going on in this chest X-ray?
This X-ray looks the pulmonary artery looks prominent, but besides increased interstitial markings and hilar prominence, looks like chronic lung disease, but I'm not seeing anything acute. Trachea midline. There's some apical lucency, but I'm not concerned for like a pneumo.
Good. Right, so quickly go through the that whole algorithm you have for chest X-rays in your head, right? Because there is something that's concerning on this X-ray.
So let's do the algorithm. A, airway looks good. B, bone looks great. C, cardiac. Is that a subtle? I don't know. Is there a lucency around the pericardium?
The pericardium is fine.
Okay. So cardiac's fine. Diaphragm, from what I can see, looks okay. Anything else? No, I don't see anything. What am I missing?
What did we talk about when we, what's the F in X-ray?
Oh, F? I use A, B, C, D. What's the F?
Foreign bodies.
Foreign bodies, I'm saying. All right, so.
Right, you have to account for everything that's abnormal on the X-ray that shouldn't be there, right? So you see like lines, you see wires, right?
Is that yours?
So what do you notice about this?
Yeah, is that yours?
Yep.
From that guy?
Yep.
Oh, that is pretty okay. That's not supposed to be there. Let's clap. Well, that's a good example because I had a similar case. That's a very good point in residency. They kept thinking it was like a wire the whole time. And it ended up being like the guide wire was somewhere, basically someone left a wire inside somewhere. So yeah, every foreign bodies, I agree. Never forget the F.
It's a foreign body that's supposed to be there, right? That's a central line. I promise you, I did not leave the wire inside. You can see that the wire, it's a left-sided IJ, right? And so there's a central line going in. So what happened here was that I put the central line in a patient that required resuscitation. They were on like a lot of pressors. And then I'm getting no resistance when I put the wire in, right? And then I advance, do everything right with the central line. I transduce it because the patient requires immediate use of pressure, so I don't wait for the X-ray. And then I transduce it. Everything looks good. It looks venous. So we go ahead and use it. About 20 minutes later, I get the X-ray. I see it because I finally come up. And this is the chest X-ray that I get. So what do? I run back to the patient room, ask them to stop the pressors, quickly put a peripheral IV in so they can use the pressors on there. And I'm like, crap, right? This patient needs to go down for a CAT scan. But what doesn't make sense to me is that where do you think the central line is? So, the CT was done. The radiologist initially read it as going through the internal jugular, puncturing the brachiocephalic, entering the lungs, going through the lungs, and puncturing the mediastinum of the heart, the pericardium of the heart, and ending there. That makes no sense to me because one, the patient is extremely stable. There's no pneumothorax. And then we did get a VBG from the central line as well as peripherally, and we looked at the VBG, and the numbers shows that it's venous blood. On top of that, we connected the transducer again, and we're still getting a venous waveform. And I'm still getting the fact that I'm getting blood tells me I'm probably not causing all this damage. So I had another radiologist who read it as going into the left IJ and going into the left-sided superior vena cava. It's just very collapsed. And so the management for this patient is that you have to get an echo to look for an enlarged coronary sinus, because a large left coronary sinus is usually associated with abnormal anatomy, specifically a left-sided superior vena cava, which everyone has, but it usually collapses. It's a congenital abnormality. And then what you also have to do is an echo with a bubble study, because in some patients, the left-sided superior vena cava will enter the left atrium, causing a left to right shunt. And so it's just one of those things that you have to know. Unfortunately, I knew it because I dealt with this patient. So, I spoke to one of the attendings afterwards, and they also had it happen to them. And their advice was, everyone loves to go for the left IJ in a patient that has an AKI because you may need dialysis, but this may cause you some pause before you go for that left IJ. And you can, if you need to, insert a trialysis catheter on the left IJ. It just doesn't flow, it just doesn't go as well. So you have to be careful about that. Questions about that one? All right, cool. 46-year-old from a rural facility, septic shock, hepatic failure, vancomycin, blah, 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 antibiotics. You see petechiae, but it's important to look at the numbers. You see a low white count, low hemoglobin, low platelets. Fibrinogen is high. You see the smear is negative. Their liver chemistry tests are insanely high. Their bilirubin is insanely high. And then the number that really gives it away is the ferritin. It's in the 5,000s. And the number that gives it away is an interleukin 2 receptor, which is the CD25. You're almost never ordering that except in what test? And the right answer here is HLH. It's, if they're giving it to you away, I thought that was a bit easy. You really should just require the ferritin, and that should give it away, because it shows that the patient has an overt amount of inflammation, right? Why do patients die from ARDS? Why do patients die from sepsis? Same thing as HLH. It's an overt inflammatory response. Basically, you have your natural killer cells and your cytotoxic T lymphocytes, which are responsible for clearing macrophages, going into overdrive. In children, it can be an inherited disorder, and you will detect that via congenital genetic testing. But in adults, you have an acute insult such as lymphoma or a viral infection such as Epstein-Barr virus, which will cause you to produce a secondary HLH syndrome. And you're really looking for, there's like 8 criteria to diagnose this, of which only like 5 can you actually get routinely. You look for fever, splenomegaly, which you can do with ultrasound, as seen below. You can look for cytopenias of at least 2 bloodlines. What you're looking for is a hemoglobin less than 9, an ANC less than 1,000, or a platelet count that are less than 100,000, hypertriglycerides, or hypofibrinogen. And then if you're able to get the test, you can do a bone marrow test or from, a lymph node, and you'll see hemophagocytosis. You'll see decreased natural killer cell activity, and then you'll get that testing for CD25, which will be high. The other one that you can get readily is the ferritin level, which will be insanely high. And the treatment here is obviously treat the underlying cause, steroids. And then there's, some mixed evidence on which one to use. The most common one that you'll get tested for in your board is etoposide. But you can also consider like IL-1 antagonists. Yeah. Important has to think about in a patient who's very, very ill and they get pretty ill quickly, who you're suspecting an overt inflammatory response. 2 more left, we'll be quick. You have a patient, or you're like, this is more like a QI question about PICC lines versus central lines. The right answer I'll get to in a second. But really what you're looking at is important to know the difference between PICC lines, midlines, and central lines. So, PICC lines and central venous catheters are technically central lines. The difference is that PICCs you're inserting peripherally. And the idea is that you can go with longer access than a regular central line because it's not through a central vein. And then a midline is not a central line, right? It's still going peripherally. Also, by the way, in case you guys don't know, at Molecular Hill, you can place your own midlines. We have the kits for it, so I do recommend doing that, especially in the middle of the night. Instead of doing an IV access, because just a regular peripheral IV, because then if you're putting a regular peripheral IV and they're going to need the midline anyways, then you're kind of ruining the access for them. Which is why we try and avoid PICC lines in dialysis patients, because you're once again ruining the access for them. And then a tunnel catheter, these are all non-tunnel. A tunnel is pretty much, it goes under the skin for a bit and then goes into the vein, so you can use them for longer. But things to know is that when you look at, the idea is that, okay, we thought that, PICCs would have a decreased risk of infection, but it is a central line. So you're going to get the same risks of infection and a 4 times higher risk of infection compared to peripheral IVs because it's central. And when it comes to clots, because they're going peripherally and you have a smaller vessel, you actually have a 2.5 times higher risk of a clot compared to a central venous line. So just be careful about that when you are prescribing PICCs. And really, I think here, when it comes to infections, it's the number of times you end up opening that catheter to use it. Last question I'm asking about
central lines after trauma.
Sorry?
I said you just hate central lines after your trauma.
I mean, I do love putting central lines in. I'm not gonna lie, especially subclavians, but I think I pretty much tend to tell my patients, because you're resuscitating everyone. Ideally you want to avoid doing central lines emergently. If you have to, you have to. But the biggest mistake I see people making mistakes with central lines is that when they're doing it in a rush. Like, doing it in a rush doesn't mean forgetting your steps. And the more you practice all your steps when you're doing them in a slow setting, the better when they require to be placed emergently, you miss mistakes. Like, this patient, anyone could have said that I accidentally caused that trauma, and because the patient was being resuscitated very quickly, but I did not pass that wire without resisting resistance, and I still transduced it because of the same steps that I practice when I'm doing it slowly. So I knew that, yes, I'm freaking out because of the chest X-ray, and I'd never dealt with this before, but absolutely I knew that there's no way that I would have punctured this because I never got any resistance. So next question about gastric residual volumes. You guys have probably heard this all the time. Oh, should we stop feedings? The GRVs are more than 200, 250. They haven't had a bowel movement in a couple of days. Well, this is kind of where we do things that are a bit unnecessary. So there is no good evidence that you should be stopping tube feeds for patients that have high gastric residuals. It's something that we hear a lot. There used to be a concern that they will aspirate, but when, what they did was, in studies where they checked patients who were checked patients who were on the vent getting feeds, they saw that, ignore the PIC thing, but they saw that in patients who you were routinely checking gastric residuals on versus not even checking, patients had a higher incidence of detrimental calorie deficits in patients where GRVs were checked. And really what you should be looking at is other things. You should be looking at like abdominal distension, vomiting, regurgitation, reduced bladder stools, abnormal chest X-rays. These are the things that you get concerned about why you want to stop feeding. And you should have a very, very high threshold for stopping feeding, because patients in the ICU who cannot control their own nutrition, or even who can, but are ill, critically ill, are less likely to be getting adequate amount of enteral feeding. And then they decondition very, very, very quickly. Up to 1/3 of patients in the ICU are not able to tolerate feeding. And so it's very important to be vigilant, always push for a very good reason to stop it. And then, when you talk about like volume-based feedings versus hourly targets, if you achieve a goal volume, that versus, hourly rate, that has been shown to have a higher number of patients who get adequate and enteral nutrition. So, the recommendation is to not use GRVs as your indication of enteral feeding intolerance. Really use other measures, fine. If it's like greater than 500, figure out why it's greater than 500. Why are they not absorbing it? So the next time a nurse says that the patient has a high gastric residual volume, you say, I don't care, keep feeding, or doing the right thing and going to assess the patient. That's all I have. Any questions?